So on this note, I invite Dr. Gaurav to give his talk on minimally invasive glaucoma surgery. He's been a glaucoma fellow at PJ Chandigarh.
Thank you so much, Dr. Sundar, for a kind introduction. At the outset, I would like to thank POS and AIOC to give the opportunity to speak in front of you all. So the term MIGS was first seen in 2012 as an umbrella term which for devices or treatments which has main 5 features, that is ab interno microincision, that is conjunctiva sparing surgery, because previously all the surgeries involve the opening of conjunctiva. Then minimal disruption of anatomy, lowering of IOP at least 20%. It has rapid recovery and high safety profile. So why MIGS? Because from a traditional surgery, MIGS have significantly lower complication rate, faster recovery time, less postoperative care, and possibly earlier intervention, and quality of life impact is very much lower. So, but still, although it seems very promising, but there are a lot of limitation of this procedure. It is not an effective in advanced cases. Long-term safety data is still unproven. Cost is a major challenge in developing countries. Also, it has a bit of learning curve because we need to be skilled in gonioscopy and specifically intraoperative gonioscopy. And patient selection is critical. So main question is when to do MIGS. Are all patients fit for MIGS? No. So the patient in which glaucoma patients have requiring treatment, if IOP is uncontrolled despite maximum medication, then still the gold standard is trabeculectomy or any glaucoma drainage device. But if the IOP is controlled on topical medication or it is in early phase, then we should look for if the patient is having cataract or not. If there is no cataract, then we can do mild to moderate glaucoma standard on MIGS, which is trabecular meshwork based, or GATT. If cataract is present, then we can combine MIGS with cataract surgeries. So based upon the utility of or the mechanism of action, there are various kinds of MIGS, but majority of MIGS work on trabecular meshwork. One Zen implant came which worked in subconjunctival space. Suprachoroidal space, CyPass and iSense Supra are there, then ECP are there, but majority, I think MIGS work on trabecular meshwork. So indications are specifically mild to moderate open angle glaucomas in combination with cataract surgery and ocular hypertensive patients who do not want to put medication. So there are very basic requirements to start MIGS, that is equipment and skill. So in equipment, not much of things are required. You just need a direct gonioscope, which is the most commonly Swan-Jacob lens is used, and a good microscope with tiltable head, because we need to tilt the microscope at 45-degree angle to see the angle in these cases. Then learn the art of gonioscopy. First learn it in clinics and then intraoperatively. You can learn the art of gonioscopy in routine your cataract patient before starting MIGS, but you need to learn this, because if you are not able to visualize the angle intraoperatively, you will not be able to do MIGS. So the popular MIGS, as there are a lot of implants, but non-implant based MIGS are popular in India, like BANG, KDB and GATT. BANG is basically bent angle needle goniotomy. Nowadays, it is the most commonly done MIGS procedure in India. And I think all cataract surgeons who are doing cataract surgery in glaucoma patients should do cataract with BANG nowadays. So I'll be showing a video. So this is a video of goniotomy in a pediatric patient. It is very handy in those cases. This is Swan-Jacob lens. Here we can see with the help of needle, we are just slicing the trabecular meshwork. So it helps you identify the structure very well. So now coming to bent ab interno needle goniectomy in primary angle closure glaucoma. So first you need to bend the needle, your 24 gauge needle, towards the bevel at an angle of 40 to 90 degree. Then this is a case of angle closure glaucoma with 18 IOP on 2 medication, and cataract surgery was required. So then use a direct gonio prism and visualize the angle structure very well. So once you visualize the angle structure, then you insert the needle, and then you can see here, you just slice the trabecular meshwork. You need to identify the trabecular meshwork first, then you just slice the trabecular meshwork. and just strip off. There is minimal amount of bleeding. We can treat 100 to 120-degree angles and then do a routine cataract surgery like we do. So there are a lot of data published on Bang. This is a study by Dr. Tanush Dada, and they have demonstrated that at 12 months, 87.5% cases had actual surgical success, and they noted surgical success in more than 20% of IOP reduction. So another is GATT, that is gonoscopy-assisted transluminal trabeculotomy. In this, we treat 360 degree of angle. It can be done with the help of illuminated microcatheter, that is eye track, or just with the help of Prolene suture. And GATT is the angle surgery which controls the IOP maximum. It controls almost 45% of pressure at 4 years. But this is the long-term study demonstrating the outcome of GATT, and they says that at 4 years, almost 50% fails. But initially, there was a 45% reduction. So long-term success is still questionable in these cases. So the other popular MIGs are like iStent, Trabectome, Hydrus, Omni, Streamline. There are a lot of things coming up. So iStent is an implant which comes preloaded. It is inserted into the trabecular meshwork. It bypasses the TM and it directly drains the aqueous into the Schlemm's canal. It is loaded first and then directly inserted with the help of gonioscopy assisted. So this is a study which shows that it is comparative data in which cataract surgery alone was done and then cataract surgery with iStent was done, and they found superiority of IOP control with the help of iStent. This is a Hydrus implant. Hydrus implant is another implant which is 8 long device. It is implanted into the Schlemm's canal through the gonioscopy assisted thing. And in this, aqueous is outflow into the Schlemm's canal and into the distal outflow veins. So this is a study study which compares the data of Hydrus with iStent. They found that iStent has inferiority over Hydrus implant, but Hydrus implant is, I think, it's not available in India right now. Then iStent Supra is there, which drain the aqueous in the supraciliary space. Then Cyper stand came. It was very promising because it drains into the supraciliary space, but it was then withdrawn. Then the Zen implant came. It was very promising because it was draining into the subconjunctival space. There was no opening of conjunctiva. It was loaded from the angle into the subconjunctival space, and it has perfect lumen of 45 micron, but it also failed. I personally feel all this fails because subconjunctival space is not a potential space, and the body tries to heal everything, and once it heals, they tend to fail. So take-home message for today is that the MIGS is bridging the treatment gap between medical therapies and more invasive surgeries, and can be performed as a solo procedure combined with phaco. But in today's scenario, if we are doing a phaco in a glaucoma patient, we should all learn MIGS, specifically Bang, so that we can do in those cases, because it causes 20% reduction additional IOP in those cases, and also prevent the IOP spike in glaucoma patient. It just requires gonioscopy scale and basic instrumentation, nothing much, and can be easily started by a cataract or glaucoma surgeon. But the most important thing is not a procedure for advanced glaucoma, and TRAB remains the gold standard in advanced glaucoma. So, thank you.
Gaurav, very nice presentation. I have just a couple of questions, In our Indian scenario, of course, Bang remains the treatment of choice,
Yes.
What is your experience with the Bang, or what does the literature say about Bang? How much IOP lowering is there with this? And how long does the effect last?
Sir, I personally feel that whatever MIGS we do, majority have 20% reduction, and it is a good case. If we are doing I personally do not recommend if the patient is on wandering and doing an intraocular surgery, but if I am going ahead in an open angle glaucoma for a cataract surgery, because we know that in open angle glaucoma only 2 to 3 millimeter mercury is reduced, but with combining it, Bang in those cases reduce significantly. That 20% reduction is there. If we can put them off with one medication at least after a cataract surgery, then it is a very good procedure in those cases. The study, there are a lot of data coming upon Bang from AIMS, PJ, and other centers also, that the effect lasts at least more than a year, because it is almost 20% reduction. But I personally feel all the cases in which there is single drop, because glaucoma is a progressive disease, the disease itself progresses with time. We don't know if the procedure fails or the disease is progressing, but it lasts for almost 1 to 2 years, not very long. The long-term data has not till now come up for 5 to 6 years that how it performs in long term, but at least it is effective in 1 year.
So there's a lot of, promotion of eye stent and many other stents in India, and what is their cost? What is the status today in India, and which are being used actually in practice?
So eye stent, I think a lot of people are implanting in PJ. They have implanted. It is not freely available right now in Gurgaon. Many centers are using. South, many people are implanting. It costs almost 1 to 1.5 lakh single implant, but one implant reduces only 20% reduction. And I feel personally, coming from India, and that if a 2 rupee needle does the same job, then why to spend 1 lakh rupees?
And it's not probably covered with insurance also.
Yeah, yes, sir.
Right?
It's not.
So
Insurance is not covering in India right now.
Yes, please, Sanjay
Yeah,
Parul. Do we have a mic?
Yeah.
Okay.
Once they stop working, so like what is the next course of action? Do you take them out, clean them, put them again, or you put new ones, you remove them?
I think they can be left in situ because it is very small, it do not affect anything.
Because one particular doctor, he was saying that he's studying over it, whether the stent can be removed, cleaned, and then put back again, just to try to see, where the why it has failed. Whether it's the drainage part or it's the eye stent itself which has.
I think very interesting point you have highlighted. I think it is very good to know if we can remove that thing and then assess what has happened. It is the eye stent or the TM part.
So what do you do?
So I don't have personal experience of removing.
No. So what do you do like once those two stents they stop working? So you go for another two?
No. For another surgery. Yeah.
We have a couple of more minutes. We can take questions from the audience if there are any questions.
Yes, sir, I would like to ask Dr. Gaurav one thing. It was a very nice talk. So are you doing this band before cataract surgery or after cataract surgery?
I do it before starting.
Because most of the time, most of the surgeons are doing after cataract surgery, because once you remove the cataract, the angle opens up more. So it is easy to remove the trabeculum eschwa.
Yeah,
So
because I personally feel the cornea clarity is much better in before starting the surgery, and also we don't have to wait for the hyphema to wash out, because while we are doing the surgery, it completely wash out. So the chance of post-operative hyphema are less.
But yes, sometimes it bleeds a lot,
Yeah.
and the hyphema can be a problem for you doing Rexis and further cataract surgery, because it keeps on bleeding for few minutes. So doing it after the surgery, then you can put air or you can put visco, and that stops the bleeding.
Yeah, I think it is a personal experience. Of
Because I am doing it after cataract
yeah.
surgery.
Yeah, I think it is same like we have been implanting Ozurdex a lot previously when I was in PJ. We used to implant it at the end of the surgery, before the surgery, but now we are implanting at the end of the surgery. I think many surgeons implant, it's personal preference, I think.
Okay. And do you think, have you done this bang in angle closure patients?
In angle closure patients, sometimes I have tried, because we have done goniotomy in pediatrics. In those there is high iris, we just try to remove the synecdoche and then does it. But I personally feel that it doesn't make a difference in those cases, because I have seen that there is 20% reduction that already happens due to removal of cataract in those cases. So it is very difficult to comment if the effect has actually come due to bang or the removal of lens.
Thank you, Dr. Gaurav. Any questions from the audience on any of the talks? We have 2-3 minutes. Talveer, I would just like to ask you, do you do diurnal variation routinely in your glaucoma suspects, or you believe split diurnals are as good as that?
Usual office timings usually start at 8, So if you want to do an actual diurnal, the 7 a.m. or 6 a.m. IOP is something which you would really want to look at, because most commonly in around 70% of people, the morning IOP is the peak IOP. So if you can call the patient at 8 a.m. to your office and you're doing a diurnal, if it is not available in government medical colleges, we can still have, because in the ward we have a slit lamp, we can ask the patient to come to the ward and get an IOP done, right? But in practice, it's usually not possible. So we can do a split diurnal, or actual diurnal phasing usually needs a early morning IOP. So that is something which has to be looked at.
So Gurvinder, so how many cases you do, like 10-2, in all cases you do, or you do in only if there is a central involvement is there?
Advanced cases we do in all the cases, and as you pointed out, if we have the inferior notch, then 10-2 is done routinely. And if the glaucoma is progressing, then also I do 24-2 along with 10-2. Our perimeter doesn't has the 24-2C with it.
So basically, if there is central 10-degree involvement is there, some you find some points there, you know, then you probably go for 10-2, not otherwise.
Not otherwise. Yeah. Or if it is advancing, the glaucoma is
So
advancing fast.
I just want, my take on this is that if you have a little iota of doubt about the disc being glaucoma disc, do go for 10-2.
Beginning
Especially
only
if it is a inferior notching is there, or
inferior. So
inferior
otherwise,
thinning of RNFL is there.
in the start also we should be doing 10-2.
And I'm saying if 24-2 is normal and you don't have 24-2C, then go for 10-2 in addition to 24-2.
So the main thing is not central or peripheral, the main thing is resolution. The 10-2 has 2 degree of resolution and the 24-2C has 6 degree of resolution. So we can have skip lesion in between. So that is the main purpose of 10-2. It's not the central or peripheral thing.